Okay, guys, next thing we're going to talk about is just a little basic anatomy. Hang in there if you've already gone through this stuff pretty in depth. Obviously, feel free to skip this if you feel like you really understand this. I'm going to try to breeze through it and just make it a bit specific to what we're going to be talking about later. But I want to lay down the foundation because all these motions and the anatomy is very important when we start talking about the actual way people get hurt and also technique so that people can get back to train without getting hurt in the future. So we're going to talk a little about the shoulder, the ball and socket joint, or glenohumeral joint. We're going to talk a bit about the rotator cuff and the biceps tendon, specifically the long head of the biceps. We're going to talk a bit about the subacromial space. We're going to talk about the acromioclavicular or AC joint. AC joint is interesting because it gets irritated in a weightlifting, bench pressing, powerlifting population in a different way than physical therapists generally deal with AC joint problems, known as separations. So we're going to make it specific to our population there. We're going to talk a bit about the scapula or the shoulder blade and its role in injury, also the thoracic spine and the ribs. And the last little bit we're going to talk about is regional interdependence, which basically just means that sometimes joints that are further located from where your pain is are related to the pain problem and they need to be addressed. And we'll just talk about some specifics and some basic things that we see to be on the lookout for. So, first we have the shoulder or the glenohumeral joint. Now, we have the glenoid, which is the socket portion right here, as you can see. And we also have the humerus, or the humeral portion. So this is the ball. This is the socket right here. And this would be your arm going down here, the humerus bone. Okay, moving on. Next bit, we have the labrum and the capsule. So this is a little bit more challenging to understand what's going on right now. This right here is the ball, right, the humerus going down into the arm bone. And the socket is a little tough to see, all right? So the capsule is a series of ligaments, as you can see, that attach the ball to the socket and provide support and stability. In some individuals, this can get stretched out over time, so it's just an important thing that we're starting to look at. The other part is the labrum, right? So labrum is this thin lip here that goes along the socket, just helps to deepen the socket. Another function of the labrum is it forms a vacuum seal around the joint to increase the stability of the joint itself. And then in some individuals, this gets torn, which can decrease the stability of the shoulder. Okay. Next, we have the rotator cuff. Now, the rotator cuff oftentimes is it's not super sexy, and a lot of people kind of vilify it lately, thinking it's not that important. I'm here to tell you the rotator cuff is incredibly important, and I think people saying that the rotator cuff is not that important is just hopefully a fad that's going to fade over time. The rotator cuff is incredibly important. So we have a couple of pictures here. First, I'm going to orient you to what's going on right here. This, again, is the ball of the humerus, and again, this is the arm going down. The socket is actually right here, and it's hard to see that. This is the shoulder blade right here, okay? So the rotator cuff are a series of muscles that attach from shoulder blade to the humerus, to the ball, help to give a hug to pull the ball into the socket, all right? The top portion of the rotator cuff is known as the supraspinatus, so that's right up here. Right below that, we have the infraspinatus, okay? And the last bit right here is the teres minor, okay? And this makes up the backside and top side of the rotator cuff. Now, the other side that we don't often see is in this picture here. So to orient you, this is the front. So we're actually looking at a rib cage here, and this is the shoulder blade right there. I'll just try to draw it for you, okay? And then you have so this is part of the capsule probably, and this is the ball, this is the humerus going down, and then the undersurface on the back side of your shoulder blade or scapula is the subscapularis, and you can see it right there in that red color, okay? All very important muscles for stability. So we talked a little bit about the labrum, and then the capsule provides stability of the ball in the socket. The rotator cuff is what we call the dynamic support. That's what helps keep the ball in the socket when we're doing all types of movements, snatch, handstand, muscle up, whatever it is. Okay. Next thing I want to talk to you guys about is the subacromial space, all right? So to orient you again, we have the humerus, right? So we have the ball portion here. We have the socket. Now this is the capsule. The capsule is still on in this picture, okay? Now what's important is this structure right here, so it's the humerus, okay? And then this structure above it, this is the acromion. So this is just part of the shoulder blade. It's the acromion. You can actually feel it if you put your hand on the top of your shoulder. And it has a ligament that attaches right here to your coracoid, all right? So this little connector right here, the acromion and the coracoid, is called the coracoacromial arch. All right. Underneath of this is called the subacromial space. All right. So here's your acromion here. This is the subacromial space. This is the humerus. And you can't quite see these structures here, but your supraspinatus tendon comes out right there. Okay. You also have a bursa that lives right in this area, and you can actually see the long head of the biceps goes into this area as well. So when someone has subacromial impingement syndrome, the subacromial space is very, very important. Okay. Oftentimes the infraspinatus can be involved in this condition as well, and that's based on the orientation of the arm. So imagine if your arm goes completely overhead, different structures are going to be underneath of the subacromial space as if your arm is completely down by your side. Okay. Next we have, so I'm going to point out the scapula, which is right, or excuse me, the clavicle, which is right here. We have the scapula, again, which we talked about quite a bit, and this is the rib cage. All right. The two joints we're going to talk about next is the AC joint, so where the clavicle and the acromion, which again is part of the scapula, where the two meet. Now, a lot of weightlifters end up having pain right in this area, and that could be from a lot of bench pressing, a lot of pressing in general, a lot of deep dips. Sometimes front rack position is troublesome for these athletes because the bar presses right on this joint. Okay, the AC joint is relatively immobile, and when people tend to hurt it, it becomes hypermobile. It moves a little bit too much. And this can lead to wear and tear and arthritis, and in some individuals get a separation, and that's usually a traumatic injury from something like hockey or falling from a skiing accident. Okay, so not necessarily what we're seeing in our specific population. Now at the other end we have the sternoclavicular joint. So this is the clavicle, and then this is the sternum right through this area. Now the sternoclavicular joint is interesting because it's the only bony attachment of the arm. Right? So the scapula doesn't directly attach to the ribs via any joints. It's just all muscular attachments. So only bony attachment is this joint right here at the SC joint. Okay. The SC joint is actually relatively mobile, and it's important for bringing your arm overhead. Okay, doing all the motions of the shoulder joint. To be honest, I do treat this sometimes when people have AC joint pain. Okay, I think it can be helpful, although I just don't know that we fully understand this joint very much. There's not a ton of research to show treating this joint is going to be helpful for AC joint injuries, but just important to keep in mind just the function of it, and that it is actually supposed to move quite a bit. And the function of this joint, its movement, is changed generally when people have shoulder pain, similar to scapular dyskinesia. Okay, moving on. Next, I want to talk a little bit about the basic function of the shoulder blade. Okay, so the scapular shoulder blade is meant to move, and the position of the shoulder blade is going to impact how much space is in the subacromial space, and that's why it's important that we understand the different motions of the shoulder joint. Okay, so when I bring my arm overhead, one of the functions of my shoulder blade is to upwardly rotate. Okay, so this is the edge of my shoulder blade, and when my arms are at rest, it should be pretty much vertical. All right. So as I bring my arms overhead, I have my shoulder blade upwardly rotates just like that. When I go back down again, it downwardly rotates right back to here. Okay. Now this is an important motion because it increases subacromial space, and we'll talk about that a little bit later. But it's important that we understand this motion, and if people are not getting enough upward rotation, we probably have to make sure they get enough. Okay. The next piece here is anterior and posterior tilt. So I tried again to take a picture of myself from the side and put my shoulder blade into a position of anterior tilt. So imagine this is my shoulder blade right here. I'm tipping it forward. Okay, that's the anterior tip portion of it. All right, just think about the anterior tipping is tipping forward in this direction, and that's that kind of forward shoulder posture that you'll notice, the protraction that you'll see at people in the bottom of a dip. All right, or at rest. So I have a decent amount of this at rest. I don't have the greatest shoulder blade position, as you can see. The position that we do want to try to obtain is called posterior tilting or posterior tipping. So what we're doing is we're taking the shoulder blade and we're trying to tip it backwards. Okay. Now, if you take a look at this, if this is my acromion right here, if I tip my shoulder blade backwards into this direction, what ends up happening is I end up increasing the subacromial space. So you can see right away this is a good motion for me when I'm trying to do something like press weight overhead. Okay. And the last motion we'll talk about a little bit is external rotation and internal rotation of the shoulder blade. Now, I think this is just a tough movement to understand. So again, I tried to give some images. So if we're doing an external rotation of the scapula, it's also coupled with, we call it retraction. So bringing the shoulder blades together, we're taking the shoulder blades and we're externally rotating them. And then the opposite would be internal rotation, and that's also coupled with the protraction or anterior tilt or tipping that we are talking about earlier. Now, the reason why this is important is because subacromial impingement is affected by the position of the scapula. Okay, so we're just talking about the subacromial space and how the biceps tendon lives in there and how the rotator cuff tendon lives in there and the subacromial bursa lives in there. So having increased upward rotation, posterior tilt, and external rotation brings the acromion away from the subacromial space. So what that means is when you're exercising, it's reducing compression of the cuff, of the bursa, of the biceps. So now it's important for you guys to understand the positions of the shoulder blade because the positions of the shoulder blade are directly affecting how much compression you're getting when you exercise. Okay, and we'll talk a little bit later about exercises like the snatch, like dips, and trying to get good positioning so we maximize the subacromial space. Okay, next thing I want to talk about is dyskinesia. So dyskinesia is basically abnormal or altered motion of the shoulder blade. And I got to tell you, it's a little bit poorly understood. So people that have shoulder pain generally also have dyskinesia. However, people with shoulder pain don't always have the same type of dyskinesia. Some people might have a little bit more upward rotation, less upward rotation, more retraction, more protraction. So we don't really fully understand that, okay? So pain can be a player. So maybe when you have dyskinesia, your body is moving in a way that's trying to avoid a sensitive structure being compressed or stressed, right? Maybe you have specific weaknesses. Maybe your serratus anterior muscle is not doing its job, so we can't upwardly rotate well. This is oftentimes associated with nerve injury, long thoracic nerve being one of those. If you have cervical radiculopathies, problems with the neck, this can also lead to problems as well. And the other piece is that you can have tightness. So if your pec minor is tight, it's going to tend to anteriorly tip your shoulder, right? If the internal rotators, the lats, the pecs are very tight, or much stronger and the balance of the retractors or protractors is off, a lot of times the shoulder will sit into relative internal rotation. Again, that's going to provide a little compression on those structures that we talked about before within the subacromial space. And the last little bit is the thoracic spine is going to affect the position of the scapula, which we'll talk in a second. And if it's stiff, then we're not going to be able to get the shoulder blade in a good position. And the last question is, does it really matter? Okay. So again, this is kind of a poorly understood thing. And a lot of people will say if your shoulder blade is not moving properly, we need to really focus on muscular balance, make sure that the upward rotators are working well, making sure they're not getting overactivation of the upper trap. I do believe that's part of it, but I will say that it really depends on the pathology and the individual, right? So if someone is stiff, we have to loosen them up. If they're weak, we have to get them stronger. If they have pain, we have to get them out of pain. All right. So when people present with this dyskinesia, we can start to think a little bit about why they're having the dyskinesia and how to adequately treat that. Okay. So the last piece I wanted to talk about in this equation is the thoracic spine and rib cage. And you're welcome for this beautiful picture here of myself. So anyway, the scapula sits on top of the rib cage directly. Okay. And the rib cage attaches directly to your thoracic spine. And I wanted to say that if you flex your thoracic spine, that's going to change the contour of the rib cage, and now the shoulder blade is going to sit into a different position. Can you kind of see that there? Same thing happens if I extend big time from my thoracic spine like I did in this picture, then automatically my shoulder blades come back a little bit. I get a little bit of posterior tipping or tilting. So if you address the thoracic spine, you end up having change of the scapular orientation, and subsequently you change what's going on inside the subacromial space. All right? What we say is that the thoracic spine is probably the first important baseline. It needs to be corrected first before you worry about things like the internal rotators or potentially pec minor or whatever it is. Because if we don't address this issue right here, then nothing else will end up clearing up. Okay? So again, thoracic spine extension is coupled with posterior tilt of the scapula, okay, so staying a little bit more upright, avoiding the position right here, and also external rotation or retraction, right, of the shoulder blades. Thoracic flexion, on the other hand, is associated with that anterior tilting. So remember when the shoulder blade was sitting in this direction, right? And also internal rotation, which is part of protraction. Okay. Last bit I want to talk about is regional interdependence. And that's basically how different joints potentially affect the shoulder. All right. I like this snatch example. So in this athlete over here, they're very, very upright. The torso is nice and upright. Okay. Now, if this athlete was having ankle dorsiflexion limitations or having hip flexion limitations, what would probably happen is that they would have a forward torso inclination. And if the torso is no longer able to stay upright like this, then the shoulder joint will have to make up for that lack of range of motion. And now we're getting hyperflexion of the shoulder joint, which we'll talk about a bit later, could also lead to subacromial impingement syndrome. Okay, so an individual that has tight ankles and they have tight hips and they hurt when they snatch, this is a good example of how regional interdependence is playing a role. If we get them more mobile in the ankle, a little more mobile in the hip, this shoulder will take a little less stress over time. Okay. Same thing happens when you see someone who gets lumbar flexion in the bottom of squat or butt wink. If the lower back starts to round a little bit, it's going to pitch the torso forward again. Now the shoulders will have to hyperflex to get into a better position to hold this weight overhead, and all of a sudden the stress on the shoulder joint increases. Okay, so that's how regional interdependence plays a role. We got to be on the lookout for it.